Hello, so this is the Chapter 33 lecture. It will cover the reproductive system. This begins on page 562 in the textbook. Figure 33.1 details the female reproductive system. There's a diagram and labeling provided. Again, this is on page 562 in the text. So the female organs and hormones, or the female reproductive system, rather, I'm sorry, is composed of the organs and hormones that allow females to reproduce and give them their gender characteristics. So the anatomy consists of internal organs such as the two ovaries, two fallopian tubes, uterus, and vagina. External genitalia would be the vulva, including the labia minora, labia majora, and the clitoris. So the reproductive cycle refers to the menstrual cycle, which has two stages: ovulation, which prepares an oocyte for fertilization, and menstruation, which dissolves the unfertilized oocyte and sheds uterine lining. The average female reproductive cycle runs on a 28-day period, where LH and FSH cause the release of ovum. The mature egg passes into the fallopian tube and then into the uterus. Estrogenic hormones would include estradiol, which stimulates development of uterine lining and mammary glands. Estrone, mostly converted from androstenedione, and I'm sure I butchered that a little, in fat and other body tissues. And estriol formed when estradiol and estrone are metabolized. And progesterone develops the endometrium and the mammary ducts for lactation. Menstruation occurs if fertilization does not take place. Corpus luteum disintegrates and endometrium is shed. If pregnancy occurs, corpus luteum continues to produce estrogen and progesterone until the placenta is developed, at which point the placenta takes over production of these hormones. Premenstrual syndrome, or PMS, occurs in 75% of postpubescent women. Premenstrual dysphoric disorder, or PMDD, is a more severe form of PMS, occurring in about 8% of women. Hormone contraception. This is on page 563. So during pregnancy, FSH and LH are inhibited, so no other follicle can develop. Hormone contraceptives use this mechanism of action. There are two types of hormone contraceptives: estrogen and progesterone combined, and progesterone only. Pre-fertilization mode of action, or MOA, prevention of ovulation, and thickening of cervical mucus as a barrier to sperm. Post-fertilization MOA, or mode of action, change lining of uterus to block implantation of the embryo. So on page 564, we have table 33.3, which details examples of hormone contraception. I'm not going to read through the table, but I highly suggest that you do so. We have table 33.2, detailing drugs and herbs that interact with oral birth control. And that is found on page 565 in the textbook. Before I move into that. So just with drugs and herbs that interact with oral birth control. If you are not already aware, please know that anytime an individual is on one of these hormonal birth control or contraceptive options, and they need to take an antibiotic or certain herbs, antifungal even listed here, fluconazole, and these certain anticonvulsants, these individuals are no longer protected for contraception through their mode of birth control. They will need to utilize a backup method if they are placed on one of these medications that interact with that oral birth control. and not just for while they are on this particular medication that is interacting with your birth control, but for a full 28-day cycle after they complete the therapy that interacted with that birth control to stay fully protected for conception. So, again, hormone contraception does come with some side effects. They may include weight gain, mild headaches, breast tenderness, nausea and vomiting, hypertension, decrease of libido, can also cause vaginitis, vaginal skin irritation, and vaginal discharge. Some toxic effects that come with birth control, and this is on page 565. It's the bullet points along the left. So, toxic effects may include a shortness of breath, chest pain, stomach or intestinal pain, severe lingering headache, changes in vision, such as blurred, flashing lights, or diminished vision, infertility for 3 to 12 months after discontinuation. Um, can also develop blood clots, and not just for the cycle, but also in the lung and brain. So, there's a risk of stroke, liver tumors, and gallbladder disease. So, hormone contraception is contraindicated for women who are pregnant or suspect that they are pregnant, women who are breastfeeding, experience unexplained vaginal bleeding, experience migraine headaches, have active liver disease or hepatitis, or a history of liver tumors. Women who have breast cancer or a history of breast cancer or cancer of any reproductive organs should not be taking hormone contraception. And anyone that has a history of heart disease, stroke, or high blood pressure, blood clotting problems, or diabetes should be cautious using contraceptive hormone contraception. I'm sorry. So there are some topical contraceptives available. Most of these are going to be in the form of spermicides. And then we also have contraceptive devices. These are barrier devices. So we have the male or the female condom, diaphragms, cervical caps, and nowadays we even have intrauterine devices or IUDs. So table 33.3 compares the male and female condom. This is found on page 566. So you can see it lists out the brand names, details how they are to be used. Also gives suggestions regarding lubricants, things of that nature. And then the specifications for each. Again, I'm not going to read through the finer details of the table, but I do suggest that you look through that when you go back through the material on your own. So next we're going to look at menopause. This is page 567 in the textbook. So this is a normal process for women in middle age. It's the final menstrual period and reduced functioning of the ovaries. Hormone levels are lower and ovulation stops. Symptoms can include bone loss, hot flashes, insomnia, sleep disturbance, and vaginal dryness. Over the counter and prescription medications are available to help with these symptoms. Hormone replacement therapy may also be considered, and then some lifestyle changes can make a difference as well. Table 33.4 at the bottom of page 567 details pharmaceutical treatments for menopause and gives you some more detailed information about them. Pelvic inflammatory disease. So this is a painful inflammation of the female reproductive organs within the uterine lining, fallopian tubes, and ovaries. So treatment would include certain antimicrobials. IV antibiotics can be given to treat the condition and may include an in-hospital stay or outpatient options. Page 568, we have female hypogonadism. This is inadequate production of estrogen in the ovaries. Women with this condition may lack a menstrual cycle and have stunted breast development. This is treated with estrogen and progestin. Table 33.6 on page 568 details the pharmaceutical treatments for female hypogonadism. Next, we'll look at the mammary glands and childbirth. So secretion of oxytocin causes labor contractions, milk to secrete, and prolactin, which causes milk production. Female infertility is defined as the inability to conceive after 1 year of regular unprotected intercourse. This is page 569. So some causes of female infertility can include age. A woman's age, more accurately, the age of her eggs, can contribute to infertility. Weight. Fat cells make 30% of estrogen. However, overweight patients have an overload of estrogen that throws off the reproductive cycle. Endometriosis, which is a condition in which fragments of the lining of the uterus are found in other parts of the pelvic cavity. Hormonal changes. About 1/3 of infertility cases can be traced to ovulation and hormonal problems. Progesterone deficiency, or PCOS. I'm sorry, my eyes floated to the wrong line. Progesterone deficiency refers to progesterone not producing enough progesterone, which keeps the uterine lining ready to accept implantation. Then we have polycystic ovarian syndrome, or PCOS. This occurs in 6% of women and is the major cause of infertility in American women. So PCOS increases androgen production, producing high LH levels and low FSH levels. This prevents the maturation of eggs, so eggs are not released. Elevated prolactin levels. In women who are not lactating, increased prolactin levels inhibit ovulation and may also indicate a pituitary tumor. And then it also says that Parladel would be the drug of choice for those cases. Medications, because certain medications can cause temporary infertility. Antibodies to sperm. Some women have antibodies to sperm that attack sperm as if they were harmful foreign bodies of substances, and therefore they cannot make it to the egg for fertilization. So pharmaceutical treatment of infertility in women. Examples would include clomiphene, which tricks the brain and pituitary gland into thinking that there is less estrogen available in the female's body. This stimulates the pituitary production of FSH and LH, boosting follicle growth and the release of mature eggs. So risk for infertility treatments would include toxic effects. More than 1 year of use increases the risk of ovarian cancer. Chance of multiples and low birth weight increases with the use of fertility drugs as well. On page 570, well, it begins on page 570 and carries over to page 571. Table 33.7 details the pharmaceutical treatments for infertility. Again, I'm not going to read through the details of the chart, but I highly suggest that you do. So now I'll be moving into the male reproductive system. Some of you may want to pause here and take a break before coming back to complete the lecture portion. So the male reproductive system begins on page 572 in the text. Figure 33.4 details the anatomy, diagrammed and labeled out. So the male reproductive system anatomy consists of the prostate. Secretions produced in the prostatic glands empty into the urethra during ejaculation via the prostatic ducts to make up a sizable volume of ejaculate. The testes, which is a pair of organs in the scrotum and surrounded by a thin mesothelial membrane. These are responsible for the production of sperm and androgens. So male infertility. Fertility in the male begins with the production of gonadotropin releasing hormone, GnRH, in the hypothalamus, sorry. So GnRH instructs the pituitary gland to manufacture FSH and LH. FSH causes sperm production. LH stimulates production of testosterone. So the life cycle of sperm runs about 70 to 75 days. 100 to 300 million sperm per ejaculation. About 400 survive acidic environment of the vagina, and about 40 reach the egg. On page 573, table 33.8 details categories of male infertility. Again, I'm not going to go through the finer details, but I highly suggest that you do. So some causes of male infertility. Autoantibodies caused by infections or injury. Retrograde ejaculation. Cryptocriticism. And I may have said that slightly wrong, sorry. And certain medications. So things that increase the male infertility risk would include, and this is page 573, the bullet points: smoking, poor nutrition, bicycling, oxygen-free radicals or oxidants, exposure to certain chemicals, hypogonadism, autoantibodies caused by infections or injury, retrograde ejaculation, cryptorchidism, and certain medications such as anabolic steroids. Erectile dysfunction. This begins on page 574. This is just another way of referring to impotence, and impotence is defined as an inability to sustain an erection for penetration. So there are many causes, including stress and poor health, and there are currently 3 medications on the market that are freely used to treat this condition. There are a couple of others. They are a lot more invasive. So table 33.9 details the pharmaceutical treatments for erectile dysfunction. This is found at the bottom of page 574. And as you can see, there's more than just the 3. The Caverject and the Muse. Caverject, you can see, is an injection. That injection is given directly into the penis. And the Muse, it's listed as a suppository that is also inserted directly into the penis via the urethra. So that's why a little more invasive. Most people are going to try to stick to the oral options. So benign prostatic hyperplasia, or BPH. This is a non-cancerous growth or enlargement of the prostate gland. Prostate gland, is the male sex organ, more or less. It's the internal. Treatment for this would include alpha adrenergic blockers and 5-alpha reductase inhibitors. prostate cancer. This is page 576. So tumors can develop in and on the prostate. Treatment would include hormone therapy and chemotherapy. Hypogonadism, a condition in which males cannot produce enough of the male hormone testosterone. Symptoms would include fatigue, decreased sex drive, trouble concentrating, hot flashes, stress, anxiety, and osteoporosis. Treatment includes hormone replacement therapy and androgen treatment. Table 3312 at the bottom of page 576 details the pharmaceutical treatments for male hypogonadism. So let's look at sexually transmitted diseases. These are spread from person to person through sexual contact, called STDs or STIs. STD for sexually transmitted disease, STI, sexually transmitted infections. The treatments include bacterial STDs are treated with antibiotics. Viral STDs cannot be cured, but they can be managed with medications. And then there are fungal and parasitic STDs that it can be cured with antifungal anthelmintic agents. So in summary, on page 577, the reproductive system's made up of internal reproductive organs, associated ducts, and external genitalia. Sex hormones are produced in the gonads, and pharmacy technician will most frequently encounter conditions involving contraception, infertility, STDs, and BPH, which of course is the reason we address this particular topic. So that is chapter 33, the reproductive system. And I will be getting a study help guide posted up to you at some point today as well. I do apologize again that I was not available to you all this morning, but I'm going to get you the information that is needed so that you can prepare over the weekend. I hope you all have a great day, and until we meet again, bye-bye for now.